And now I will go back and give Elizabeth. Oh, come on. Okay, so today we are excited to hear about housing. Housing is something that's so near and dear to our family and the people we work with. Never seems to be enough of it. So we have invited David Bridge to speak about the H2O waiver. He and Dr. Franczak presented this kind of on a national call. So they'll talk about the waiver, and then Alex Demyan, Interim Assistant Director at Access, and Elizabeth Dakota, Housing Program Administrator at Access, will also be presenting. Now, I submitted some questions ahead of time, so they'll probably be answering those, but we'll find out from them if they would like us to be quiet the whole presentation, or if we should raise hands and ask questions during the presentation. What is your preference, Elizabeth, David, and Alex?
Depending on your time, I'm fine with answering questions during the presentation if people want to raise their hands or just interrupt or whatever, so we can keep it topical.
Okay.
Yeah, I agree. I think it'll be good for us to open up questions throughout it. So absolutely.
Okay. Okay, so with that, I will, we can start the presentation. Elizabeth is going to be sharing the slides, but we will be recording.
Excellent. And we are waiting for Alex too, but he should be joining us in the next few minutes. So we're going to actually begin with David and I. But yeah, first of all, really important, as you mentioned, Lori, we have a definite housing shortage in our community across the entire state. So a shortage with units for members to be able to lease up in, and then also though a shortage of rental subsidies. So a shortage of vouchers in our community. We have, extended wait lists where members are waiting for the resource to be able to take that subsidy and lease up into a unit. So we definitely want to make sure that we partner with our different sister agencies, with different community-based organizations that are working to try to address the housing need so that we can streamline our resources. And with that, we also have David here from Arizona Department of Housing. So he's going to work to answer the first question that was presented to us and look at it more from like a state perspective on what are the existing, what's the existing housing shortage and lack of affordability in our community. And with that, I'll hand it over to you, David, for the slide.
Yeah, so again, just background, I was with Access in Liz's role a little bit ago and worked on some of the voucher issue, some of the waiver issues before, but Liz is really taking that on now. And her and Alex have been leading that effort. So they'll talk a lot more about kind of the specific Medicaid response. But with all these housing discussions, the part that we just want to put into context is the frustration and the challenges we're having with our overall Arizona housing market right now. As Liz pointed out, we have a shortage not only in capacity, but also in just stock, as well as affordability. So those three things together are causing this kind of perfect storm. Based on our data from last year, which we're working on updating, there's an estimated just across all market categories, just in terms of unit, there's a need for another 270,000 units in Arizona right now. In Phoenix alone, that's estimated to be 163,000 new units. And you can see right now that our annual production numbers, the 17,000 is multifamily units constructed a year. The 45,000 is single family units that are constructed each year. At that rate, we're 5 or 6 years out from being able to even catch up with our current need. And on top of that, we have about 1,000, we're still one of the hot immigration areas in the state. When I say immigration, I'm talking about foreign immigration. I mean, national immigration. People are still coming to Arizona from all over the country. And so, we're not catching up to that gap that we have. And so the consequence is we have a huge supply shortage. We have this demand that keeps increasing, and it becomes especially acute when you're talking about people at the very low end of the housing spectrum. So when you're talking about individuals on fixed incomes, when you're talking about individuals like with disability income, when you're talking about other special populations, that acuity becomes much higher. Lori, question?
My question is, we have a lot of people moving into Arizona, and I know a lot of people from California and other big cities. Do we find, or do we have any census on, are they people of lower resources or higher resources? So are we adding more to the Medicaid population, or are we actually adding more people that are of higher incomes that may not be competing with the same?
Send you a little bit more data. I think it's a kind of, again, I don't know that it's isolated to any one group in the population. I think it's across the board. I think if I remember the numbers, don't quote me on this, but I think it's about 17, 18% of the population that's immigrated here on the inflow side has been people making over $75,000 a year, which would put them in the, comfortably, you can afford housing at that cost. It's not, but there are a lot of people who are coming in who are looking for job opportunities and things like that. When we look at our homeless populations, again, not that that's everybody, that's a very small subset. Most of the homeless populations we've looked at, and Liz, if you can confirm this, most of them are really are locally displaced individuals. We're not seeing huge numbers of Californians being bused here. We're not seeing huge numbers of, at least they're not becoming homeless in other places and being shipped here. If they're homeless, they became homeless here. They lost their job. They had their economic setback here. So again, going back to the affordability piece, that's the other piece of it. Right now, vacancy rates across Arizona, across all units right now are like under 5%. That's much higher when you get into the low affordable units. We have very few units that are available, below $1,000. You can see right here, the other problem is how fast these rates are going up. You can see I have the fair market rents for last year and this year. For Maricopa, Pima, and I picked a couple of balance of state counties of our smaller counties, and you can see that in all of them the rates are going up way faster than incomes and things like that. So, and you can see at the bottom we have the if you're getting the maximum amount of Social Security income in Arizona, I think it's about this doesn't include your like your food stamps and stuff, but your income or your in dollars is about $900 a month. And if you assume that people shouldn't be paying more than about 30% of their income for housing and related expenses like utilities, then most people only have $300 or $400 a month to spend, especially if they're in these like highly low income populations. And again, there isn't a community in Arizona right now that is even close to those rents unless you get into again subsidies and vouchers. And then the challenge we're really having because of this hot housing market. We've seen a lot of landlords trying to get out of, and this is not advocacy, this is just what we're experiencing. A lot of landlords trying to get out of the voucher market. They're pricing themselves out of the voucher market so that it's harder to, find units. They're using more stringent background checks. So, going back more and more years on criminal activity or, those types of things, which obviously affects sometimes persons with serious mental illness or homeless histories that may have had some type of criminal experience or, may have been locked up for a little bit as part of their experience of becoming homeless or dealing with their mental health issue or substance abuse issue. We're seeing more and more stringent requirements about like move-in costs. People are asking for higher and higher deposits or proof of income, 3 times the rent. So a lot of those types of things that are just making it very hard. And that's why you're seeing, I think Pima was the first county, but Phoenix just recently tried to pass some legislation or some laws around, not discriminating based on income type so that, somebody with a voucher is competing fairly with somebody who, is paying cash or has, earned income. So there's some things people are trying to do around that, but until we can try to catch up with some of that housing gap, right now that's the problem. And I think you're seeing it in a number of places that you probably talk about frequently and others on this call could probably vouch to too. As Liz said, it's harder and harder to use vouchers statewide. I think some of our voucher programs only have about 50% rent up, and it's not because they haven't given all the vouchers out. It's because literally the people on vouchers can't find housing in the 6 months or 9 months they have to, to use those vouchers before they have to renew them or they lose them. So we're having that happen in a lot of states or a lot of places. Again, just not being able to get, again, I think we're seeing some of that. We've seen more people, like I know on the Medicaid, before I left Access, we were seeing more people having to be rehoused because their leases weren't being renewed than we were housing new people. We have a commitment to keep people in housing once they have a voucher. And we've seen more people, again, losing their housing because their landlord wouldn't renew, not because they did anything wrong. Their landlord just didn't want to renew. So now we have to find them a new place in this very competitive market. So it's a difficult situation right now. And we could get into the dynamics and the economics of the housing situation. But I just want to give this as context to why, you know, even though we have some of these resources and vouchers, it's not as easy to deploy them as sometimes we'd like it to be. And again, you know, at Department of Housing, we're doing a lot of work around looking at non-traditional housing. Lori, you've been a big advocate for, is it the Zenny homes? There's a number of products like that where, you know, they're looking at alternative, you know, quick manufactured housing or pre-constructed housing type situations. We're not talking about mobile homes, we're talking about like real homes, but can be manufactured faster. The problem is you have to get through local zoning and find, you know, local places to site them. We're looking at, you know, again, more rapid rehousing and vouchers that we're trying to put out through, you know, Housing Trust Fund. We're looking at, you know, we've done a number of things to try to increase the number of low-income housing tax credit vouchers we can get out using some gap financing strategies. We're doing a lot of work. We've partnered directly with Access to try to set aside units in new builds so that we have dedicated units, affordable units for special populations in buildings. But again, we just can't keep up with the current demand for housing in our current market, which is complicating a lot of these homeless and mental health and other housing strategies. So anyway, I hate to be a bearer of bad news, but that's kind of the landscape that we're kind of addressing right now. And I don't know if Liz has any additional, you know, or Jen Page from Mercy Care have any other evidence of how it's kind of impacted some of their programs, their housing programs.
Yeah, we're excited to be here today, though, to talk to you about the 1115 waiver and the health and housing opportunities. So we will shift over into that, but we should make note, though, that we have made some tremendous progress as a state with being able to implement permanent supportive housing programs, primarily through our state appropriation of general fund dollars that were given to us to where we can actually pay for the rental subsidies for members, but then also by pairing it with our Medicaid covered services for covered services.
Sometimes I
provide the support services.
depends on the subject, but I sometimes am
Looks like
sorry.
we're
more involved
Hey,
or less
Len,
involved.
Len,
Like I
can
got my
you-
mail here and
Len,
crossword
can-
puzzles. Just in
Len, can
case.
you mute?
I'll be able to mute.
You
him.
can mute him. Okay.
There we go. Okay. And
Thank
then
you.
with that, I'll shift over. So yeah, the 1115 waiver is a little bit of what additional work that Medicaid and Access is trying to do about this current issue. And I'll hand it over to Alex.
One
Thanks for
question
being
too, so people don't have to take furious notes. Can we have access to the slides? You can wrap them up as a PDF or.
Yes, yeah, absolutely.
Yep.
Thank you.
Thank you.
all right. Is that me, Liz?
Yes, yeah, thank you.
All right. Hello, everyone. Good afternoon. My name is Alex Demian. For those that haven't worked with me yet, I'm well, what is my title now? Interim Assistant Director for our Division of Community Advocacy and Intergovernmental Relations,
I'm glad
or
you
DCARE, since we love our acronyms here. So I am not the housing expert. That is very much Liz and David, but I did work very, very closely with our federal oversight partners at CMS to negotiate the terms of this 1115 waiver. So I'm going to start there and sort of walk through sort of the general program goals. I know we had some questions sent over ahead of time that we're hoping are sort of answered throughout the course of this slide deck, but please, if you have additional questions or clarification that we don't hit on as it relates to those questions, please do ask up. We're happy to provide the clarification that we can, but really just wanted to give a high level overview to start of what an 1115 waiver is for those that might not be familiar on the line. So generally, Medicaid programs across the country look very, very differently, but what's consistent is they're a state-federal partnership when it comes to how they're funded. In order to maintain what's called our federal match, so that federal percentage that is attributed to the Medicaid dollars, we as Medicaid agencies have to maintain compliance within sort of broad parameters that are set forth by the Medicaid law through the Social Security Act and regulatory guidance and sub-regulatory guidance. But what Section 1115 of the Social Security Act allows for Medicaid programs to do is to design really innovative, more groundbreaking, cutting edge programming that can be implemented at the state level that might not otherwise be allowable via the traditional authorities granted under the Social Security Act. So it couldn't be accomplished through a state plan amendment. It doesn't generally fit within the parameters of Medicaid law, but it would increase and promote the objectives of the Medicaid program, increasing access to care, increasing member satisfaction, being more cost effective, all things that sort of would align with that objective. They are generally approved on a 5-year basis. They can be renewed every 5 years. For those that are familiar with our system, it's the 1115 waiver that has allowed us historically to do things like managed care, home and community-based services. If you're familiar at all with our targeted investments program, those are all features of our, have all historically been features of our 1115 waiver. They also must be budget neutral to the federal government, which means that federal spending under the waiver cannot exceed what it would have been absent the waiver. So we are subject to what's called a budget neutrality test, where we do projections internally and negotiate those projections and trend lines with our federal partners to make sure that there's agreement there on how we're modeling budget neutrality. But overall, in aggregate, the waiver has to be budget neutral for the federal government. So just a little bit of 101 on 1115 waivers. If we go to the next slide, this waiver was approved with a lot of features. It took us basically 2 years from when we submitted this renewal for us to get approval. We had to do a 1-year extension to allow, due to COVID, to allow for us to negotiate the terms around our legacy programs, but also some of our new, more innovative programs. In October of last year, so October 14th of 22, we finally got approval for our waiver for most of the programs that we proposed. We still have to negotiate through a couple features, including the ability for us to pay for 30 days of Medicaid services prior to release for members that will be exiting correctional facilities. So we're really excited to continue conversations around that, but we weren't able to get to a place of approval prior to the date we needed approval for the remainder of our program. So that remainder includes just a couple here: retroactive eligibility, home and community-based services, managed care, the sort of things that you all know very well as it relates to our Medicaid program were reapproved. And in addition to those legacy programs, we also received approval for an expanded tribal dental benefit, which was very exciting. Targeted Investments 2.0 program, which really incentivizes integration at the point of care and focuses on sort of that whole person care philosophy of treatment. So really treating people's health related social needs in addition to their physical and behavioral health needs, and incentivizing providers to meet certain milestones and metrics to drive the system in that direction based on those incentive payments. And then, of course, the reason we're here today is to talk through our H2O program, so our Housing and Health Opportunities proposal, which was actually submitted after our initial renewal as an amendment. So we're very excited that we got this one in under the wire to allow for us to work towards some of these goals. With that, what are the goals of the H2O program? So we really wanted to utilize evidence-based permanent supportive housing practices and models to increase the positive health and well-being outcomes for the target population. We wanted to, of course, reduce the cost of care to the extent we can for individuals that are successfully housed. We wanted to reduce homelessness and maintain stable housing through decreased utilization of crisis services, emergency department utilization, and inpatient hospitalization. Those are some of the things we're hoping to see go down as costs also go down. Those more inappropriate utilizations, folks matriculating through those higher cost touch points in the healthcare system. We also wanted to establish standardized training around evidence-based practices for the providers that will be delivering H2O services. Also, we wanted to integrate support and leverage existing community initiatives and resources, programs that exist currently, funding. We don't want to duplicate efforts. We actually have what's called a maintenance of effort requirement in our waiver, and a requirement to sort of show our work on how we're partnering with other state and local entities, other programming that exists out in the community, how we're not duplicating those efforts, but in actuality using these dollars to sort of expand and amplify and wrap around these supports around those programs that currently exist. So that was a big lens that we took when we were looking at how to stand up, effectively structure the program and eventually stand it up. We wanted to provide training and adequate infrastructure for the CBOs that are really involved in this work already, that might be able to now avail themselves of Medicaid reimbursement. So we know that these are going to be new services for a lot of existing providers. There are also going to be a lot of new providers that have provided these services for a long time. So really looked at the infrastructure needs that they might have to make sure that we're going to be entering into a structure that's going to have a workforce that's going to be sustainable and ready to serve the target population, and really focus on the highest acuity members first, right? We know that there are definitely different levels of need in the community, in any community. The homeless community is no different than that. So really taking a hard look at what we can do to identify the members that need these services the most, start there, start small, and then expand from that point. So in that, we're really trying to address those gaps that we've seen, that we've talked about to some degree already here today within the first few minutes of this presentation, and really try to fill those gaps with some of the resources that we now have the ability to pay for with Medicaid dollars, I guess, is kind of what it comes down to eventually. If we go to the next slide, just wanted to level set real quick around where we are in the time frame as it relates to standing this program up. As you can imagine, we have a lot of work to do to stand up basically a brand new benefit package as it relates to the target population, the services that we got approved, the providers that will be engaged in providing these services. I'll put a pin in that for a moment because Liz is going to take you through in detail what those services look like, what the providers look like. But suffice to say, with this slide, it covers about a year. So going backwards in the blue box on the left to that 10/1 or 10/14 date, that October-ish date of 2022. Ending with the orange or burnt orange box here at the end of about October of 2023. So we know that we're going to need about a year to stand this up, and we have a lot of work to do ahead of that. I've kind of been framing the waiver approval itself as the first domino that really had to fall to allow for us to start working out all of the nuts and bolts, getting really into the weeds as far as the program details, what this is going to look and feel like for members and providers and community partners. We're going to have to develop rates, claiming protocols, the provider types, policy and contract language, et cetera. We're going to have to go out and educate on all of those decisions that are made. And I think one thing that's really important in all of that is the waiver sort of set these broader parameters that we have to operate within. And then we have to describe all of those nuts and bolts in what's called an implementation plan. So we're working on that. We've been very engaged in sort of building out the detail, filling in the scaffolding of the waiver with those program details over the last couple of months. We have our first deliverable due to CMS next month, actually. So we're very excited to put that forward, but that also kicks off another sort of negotiation period, if you will, where CMS has to, again, rubber stamp our model, right? So the waiver was subject to their approval, and how we're planning to and how we want to stand up the program is also ultimately going to be subject to their approval. So that's why it's been really important. We go to the next slide for us to engage with our community partners to date, and we're very interested in any feedback you might have today. As it relates to how we're kind of thinking about this to date. Again, we have those broad parameters. The implementation protocol that we're going to submit, we'll hone in on them a little bit more. And then our last deliverable, that's called our implementation plan, will be submitted in the summertime. And that'll really nail down the timing of this all, how much we're going to pay for these services, what the systems that are going to have to communicate one another, what the timeframes for rolling out those communications are going to be, any additional resources we're going to have to bring on board will all be detailed out in that deliverable. But to date, as we're building out that scaffolding, we've done a couple rounds of engagement, and definitely this being a big part of that. But some of the common stakeholder feedback we've received to date is it's going to be really important for us to prioritize a clear and easy to use process. Basically, we don't want to put any barriers that are unnecessary. We have our federal oversight partners that we have to answer to. Of course, we have federal parameters that we're going to have to adhere to, and concessions that we're ultimately going to have to make. But to the extent we can keep the barriers as low as possible, that's sort of top of mind for us, for both members and providers, and anybody else that's involved in the care. We also wanted to, same thing with the reimbursement structure. We need to build something that's easy to access with rates that are adequate, in order to make sure that we're able to sustain these services and providers are able to deliver them to the best of their abilities. Also, developing trainings. We know, again, I mentioned it earlier, but there's going to need to be a lot of trainings to get the community up to speed. We also wanted to leverage, again, existing programs. We have a requirement to do that, but it really, from the philosophy behind leveraging existing programming to the extent we can, and coordinating with this new program, is really going to make these dollars go a lot farther than they otherwise could, and it'll also make the other dollars that are existing out there go a little bit further than they currently do. So lastly, prioritizing outreach services. Liz will mention this as well, but I'll give an early plug for it. We're one of the first states in the country that received approval to use Medicaid dollars for sort of general street outreach. Limited though they might be, we're able to use Medicaid dollars for general street outreach to really amplify some of the efforts to meet people where they are, use some of those motivational interviewing skills to engage members around their care, motivate them around care, and ultimately connect them to access, sure, H2O when it gets implemented, sure, but also other state, local, federal benefit programs that they might benefit from as well. So really, really excited about that piece as well. And that was critical from the perspective of our stakeholders also. And then potential barriers that were identified. If we go to the next slide.
We'll just pause real quick, Alex, for a question that Lori has.
Oh, yeah, sure.
Oh,
Sorry,
my question was,
monitoring.
as you're saying that we want clear processes, easy to use, try to remove barriers. We heard earlier, I think from David, that 50% of all vouchers are expiring because they can't find people to rent to, because of our tremendous lack of available units available in the Valley. So for that issuing process for these people that have vouchers that can't seem to use them because no one will take them, or they can't afford the properties, will that be streamlined to where they don't have to go through this long, tedious recertification? Just like you did have a voucher, we know we have a shortage, you're still eligible for the voucher, therefore we reissue?
We're doing a couple things on that. It is unrelated to the 1115 waiver authority, though. I just want to make sure we're clear. So with our existing state appropriation, we have done some work around extending the time a member has when they're looking for a unit. It used to be 90 days, so we've actually extended it to 180. And then one thing that does tie to the 1115 waiver is our ideas around putting up something called an enhanced shelter. So I'll talk a little bit more to that when we get to that slide, if that's okay, Lori.
Okay, thank you.
Yeah, no problem.
I miss it. I don't think I was looking at the chat. I don't think I missed anything in chat, but do we have any other hands? I have one more slide and then it's over to Liz.
I don't see any other hands.
All right. I'll just wrap up here real quick. Just won't spend too much time here. I think I'm taking too much time and talking too much anyways, but these were some of the barriers that we really wanted to be mindful of. Lack of coordination could pose for a huge issue. Lack of adequate wraparound supports. I think that was maybe one of the most important things that's buried in all of these bullet points is if we house somebody without the appropriate wraparound supports, we're not doing anybody any favors. So making sure that, you know, each person's going to have their own individualized need. We know that, but meeting that need is going to be really critical to ensure that these 6 months are used for that really important stabilization period, driving towards permanency and continuing those services after the 6 months once that permanency is ultimately attained in an ideal world, right? So that permanent housing can be maintained after it's identified and ultimately realized. So We know there's workforce shortages. We're doing things in this waiver and through other agency initiatives like our reimbursement for CHWs to try to increase the workforce that's going to be available to meet some of these needs. And needing an effective referral system. I think that really gets back to coordination between funders, between resources. We have a lot of, I think, really neat ideas at this point as far as how we're planning to coordinate around the existing resources that we do have, how we're planning to leverage the statewide housing administrator, how we're planning to prioritize members, and ultimately how we're planning to leverage the service planning process to drive during that 6 months towards a stated goal for housing permanency. So with that, I'll stop and put myself on mute and turn it over to Liz to take you through all of sort of those factors of the waiver. It does look like we have Lori's hand up again, maybe, so I'll pause.
Sorry,
Liz
I
jumps
can't
in.
help myself. Do you guys use the VSPDAT still, or are you changing eligibility of how you're going to prioritize people for housing?
Yeah, so in our state appropriation for our permanent supportive housing program, we do still use the VI-SPDAT, but mostly that prioritization is focused on our high needs, high cost members or folks who are discharging from institutional settings. So I would say the VI-SPDAT is like the third layer of prioritization right now. We are not planning on using it for the 1115 services, and I'll kind of get into that too.
Okay, thank you.
Really important. So Alex and the team went through waiver negotiations with CMS, and very exciting, got it approved. And so then what happened is CMS gave us the standard terms and conditions, and they're actually located on our website. I can send that over too, but it basically gives us the frame around how we must implement these services. So one of the most important things in there is the eligibility criteria. So according to CMS in our STCs, they must meet one of each of the following. So be homeless or at risk of homelessness, and then have some kind of a clinical or social risk criteria. So it could be that they have a serious mental illness, they're considered high cost, high needs, chronic health conditions or other comorbidities, or that they're an enrolled member in our All-Tech system. But what's important to note is that this is a demonstration period. So really what we want to try to do is focus in on a specific population we know is in dire need of health-related social needs services, so that we can demonstrate the effectiveness over the period of time to essentially be able to continue these services, for years to come. So really, what can we do to address the health-related needs of our members if we have within the Medicaid system the resources to be able to implement the health-related social needs interventions? So right now we're going through the process of further defining the criteria for which population would be eligible, starting out with our population of individuals who already have that SMI determination, and then looking at special populations from there. So SMI and homeless, and then potentially our transitioned AIDS youth population discharging out of or transitioning from foster care, our high cost, high needs population, or potentially individuals who are SMI homeless and also pregnant. So I'll spend a little bit of time on this slide because, again, CMS gave us the framework, right? They said you can pay for outreach services, you can pay for transitional housing, but they didn't say exactly how we should implement it. So we've been participating in a lot of community stakeholder sessions to really identify if the population who was eligible was members with an SMI who were experiencing homelessness, what would be the best way to implement outreach services to be able to meet the needs of those members. And so with that, we've started to develop our implementation plan, and I'll go over some of the details here. The other thing that's important to note is it's all up to CMS's final approval. So when we submit the implementation plan, if they say, hey, great, this is fantastic, then we move forward to rates and reimbursement. But they may have some additional questions or concerns with some of our ideas, and that would take us back to the drawing board. So as Alex mentioned, very exciting, the state of Arizona was approved to be able to cover outreach services. So this would not take away from the outreach requirements that our existing provider network organizations or patient-centered medical homes are required to do when it comes to their outreach and re-engagement policies for their members. But what it does do is right now, that's not a covered service. So if a case manager works to try to get out in the community to locate their member, if they don't do any kind of actual coordination with a provider or a family member and they don't locate the member, that goes in as a 0-0 non-billable note. So essentially they're unable to be reimbursed for that service. So what we're looking to do for H2O and 1115 is try to build out some dedicated targeted outreach teams. And I'll get to in a minute, but that have low staff to member ratios. So if you have an eligible member and you already are a provider network organization, you would be able to actually refer that member to this targeted team. So they'd be able to get out there into the streets, into the community, do the necessary work for trying to locate the member, start to establish relationship rapport to help them get reconnected. The other one, very exciting, is our transitional housing. So a lot of us know transitional housing is usually a 24-month structured program where people can reside in there for 24 months while they go through the necessary programming and processes to be able to really obtain stabilization. We asked CMS for 18 months because we knew that, California was awarded 6 months. We thought, let's shoot for 18 months so we can really be able to try to do something with this, but we were approved for 6 months. So nonetheless, it's still exciting, right? But this has us responsible for now being as creative as possible with understanding the needs of our members, being thankful for every housing resource that's brought into our community, and trying to design a process to be able to meet their needs. So the first is we are looking at creating a new provider type. And calling it the enhanced shelter. So kind of going back to what you mentioned before, Lori, when members have a voucher and they're out in the community trying to find an apartment, a lot of times we actually lose them because they're suffering from sleeping on the streets. They're in a shelter that has rules around sobriety requirements, and they come back intoxicated and they're exited from the shelter. So now case managers are trying to help them find available units, but they're also trying to continue to help find the member, help them get their IDs, documentation. So we really want to try to help meet that need by, putting up these enhanced shelters, looking at some of our existing providers and our community-based organizations who are providing shelter services now, provide them with the funding to be able to standardize their processes and services in ways that we're looking for, like low staff to member ratios, housing outcomes, the ability to be able to coordinate care with patient-centered medical homes to address behavioral health needs while they stay there. So really trying to use this resource, like I said, to standardize some of those practices and help give these members a safe, stable location to be able to reside in while they work on accessing permanent housing. And I'll pause for David.
Sorry, I had to unmute. I was just going to say, Liz, can you just share real quickly so people understand too? This is based on evidence that shelter transitional model was based on a lot of evidence-based practices in Arizona. CBI and a number of different partners during the housing crisis stood up these temporary these other shelters with more increased services, with longer lengths of stay, low barrier. And they significantly increased the flow through of people to permanent housing and the flow through of people to positive outcomes. So this isn't just, throwing people in a giant warehouse. This is really creating a brand new shelter strategy that really is based on services and engaging people as opposed to just warehousing people. So it really is a breakthrough. And Liz, I don't know if you want to share any of the experience you might have had with some of the bridge programs you were involved in.
I came from a nonprofit organization, was there for 13 years and helped put up their bridge shelter program in 2018. And I was able to witness for myself that it was one of our greatest interventions for being able to help our most vulnerable populations come indoors, receive actually support from peer support specialists who were also behavioral health technicians who provided a culturally appropriate response to them coming indoors, a safe place to be able to reside while connecting them to services. So one member in particular, was found during the point in time count. He was blind, suffering from cataracts, and while he stayed in that location, was actually able to go through cataract surgery to regain sight in both of his eyes while he was still going out and looking for apartments and moving into his own housing using one of the more permanent vouchers. So yeah, that's exactly it. A model where we're able to, streamline their connection to permanent housing, provide a good, safe place for case managers to be able to, quickly access their members to be able to attend to different appointments while addressing behavioral health and physical health needs during their stay there. The other, though, of course, because the housing continuum needs to make sure that we're addressing all areas of it, right? So if we don't have an avenue for people to be able to move out of the enhanced shelter into their own permanent setting, then they may end up being stuck in the enhanced shelter, which is not something we're looking for too. So we are also looking at using the 6 months of rental assistance to build out some more actual rental assistance dollars and capacity to pay for members apartments, places where they can lease up in the community on their own. So this one's a little bit tricky. So what it looks like is it's only 6 months. And so we really have to make sure that we have a long-term subsidy for the individual to be able to transition to within that 6 month period. So what we're looking at for this is giving some of these dollars to our statewide housing administrator. And so if we have existing members on our wait list right now who meet the criteria for our 1115 waiver services, then we would actually be able to assist them with moving into their own apartment, coming off the wait list early as potentially 6 months early, leasing up in their own unit in the community, and then through attrition of our long-term subsidies, assisting them with transitioning in place. So basically, we're pulling members on the wait list off earlier who also meet 1115 waiver criteria, helping them lease up in their apartment as they would if they had the voucher, and then transitioning the subsidy in the background. We currently have capacity to serve 2,450 members in our state appropriation right now. So what we would need to do is add more subsidies for members to be able to transition to. So we would also ask that our statewide housing administrator, as a part of their requirements, be responsible for continuing to coordinate with our local public housing authorities across the state, really essentially create more bridge to permanency options by having a conversation around, hey, these would be members who are already leased up in their units, that then they would be able to transition to various subsidies. But the number of vouchers we would have would be dependent upon how many subsidies we get to take part and partner with us for that long-term subsidy, if that makes sense. And we'll go ahead and answer your question, Lori.
I was just wondering if everyone knew the difference between an emergency shelter and a transitional setting, because they are different.
Yes, yeah, and we tried, and we describe it in more detail in our implementation plan for what our expectations are for the enhanced shelter. But an emergency shelter, typically, oftentimes the members don't even maintain the same bed each night when they come back, so it's not even guaranteed. And then sometimes they are also required to leave throughout the day. We know that's not beneficial. If they're kind of forced to leave the environment, what does that do for their ability to meet their basic needs and overall, and their overall sense of self, right? If I had to leave my home for a certain period of time every single day, it would impact my ability to be able to address the goals that I'm working on. So yeah, so in an emergency shelter, not necessarily bed guaranteed. They may need to leave throughout the day. There's not a low staff to member ratio. Food is often not provided. So the enhanced shelter seeks to address all of that, where members can stay there 24 hours a day, 7 days a week. They would be able to leave, of course, but to go to their scheduled appointments or whatever it was that they were actually attending to, low staff to member ratio, and then a responsibility to coordinate with the Medicaid system to address behavioral health and physical health needs, as I had mentioned as well.
We also have another question in chat. Rachel, do you want to ask it or?
Yeah, you had just mentioned that individuals struggling, they would be kicked out of shelters if they were, drinking or other problems. Does this mean that an enhanced shelter would provide drug and alcohol treatment then?
Yeah, we would require they follow the evidence-based models of housing first and harm reduction. So there would need to be policies that will work with them on creating. So if a member comes back intoxicated and it's disruptive to the health and safety of the environment, we would ask that they coordinate with our system's existing crisis units, if the member is desiring to be able to address that instance and episode. But it would not then mean that they cannot return once they've, they're no longer concerned for health and safety of the environment of the location. So the idea would be the enhanced shelter is now responsible for coordinating care. So once that member has stabilized, now they can come back. And we're essentially utilizing motivational interviewing, stages of change to help them recognize the consequences of those decisions and move forward with the housing plan.
Okay, thank you.
And just if I might, Liz, one of the other requirements that we're sort of contemplating is some version of a treatment plan, right? So those wraparound supports would also be able to be delivered in either one of these shelter or rental unit settings, right? Whether that's from their existing provider that they're engaged with, or a provider organization that sort of contracts with some of these locations to provide some services at a really reduced member to provider caseload. I think that's something that Liz will probably get into in a little bit as well. But that requirement for there to be some kind of housing treatment plan, I think, is a really important
Would there be likewise, would there be medication management and observation services or that kind of thing?
We're working through that now. So we also are going to set up a new license with ADHS. And so that's really where the licensure around medication administration versus like self-administration of medication will come into play. We anticipate that most of these locations will follow the self-administration of medication protocol. So members will have a safe place to be able to store their medications, and they would be responsible for, adhering to their medication regimen on their own. But there may be some locations where they are able to set aside a certain area that could be licensed to do medication administration, but we'll work through that further with ADHS.
And ACT teams possibly would be coming into these locations
Yes.
to do those kinds of services? Okay.
Yes, absolutely. So if a member who's on ACT is residing in one of these locations, they would treat it just as they do their home. Go ahead, Chuck.
Yeah, I'm sorry. I had a question because you were mentioning how if somebody became unstable in the transitional housing, that you would call crisis services essentially. And once that person stabilized, they'd be able to come back. Does that mean that you would actually be holding a bed for him? Because in my experience, what happens is people go out and then they have no place to return to. So what's your position on that?
Yeah, we will try to address that through our policy development internally at Access. And then some of it will also be, at the provider level too. But what we used to do and we found was very, it met the needs of our members at Community Bridges and our shelters, was we would hold the bed for 3 days unless we were able to coordinate with the location where the member was stabilizing. So for instance, if a member was in crisis, we would work on trying to help them get to the right level of intervention to address it. When the member gets there, the shelter staff are responsible for coordination of care between that provider and the shelter to make sure they're aware the member can come back. And so we used to hold it for even longer if we knew that, they're going to go inpatient for a period of time. We could hold the bed until we knew their discharge date was coming. So that would be the expectation. But sometimes if the member then maybe discharges from the hospital and doesn't willingly come back to the shelter, we would hold that bed open for 3 days while the outreach team tried to go out there and find them again to try to communicate and use motivational interviewing to get them to come back willingly.
Thank you.
So we were also approved for the one-time transition and moving costs. So this is also a barrier where oftentimes there's incidentals like utility arrears that the member can't pay for, and it prevents them from being able to lease up. So we have some budget to be able to cover those expenses for these eligible members to try to address those concerns, including home accessibility modifications and remediation. So if a member has some type of a condition in which they would need a modification to their home to be able to live independently, we have some budget to be able to address those needs as well. And then what Alex was talking to too, this pre-tenancy and tenancy support services. So what we're looking at is really dedicated support service providers following our SAMHSA fidelity model for permanent supportive housing to be set up and in position to be able to provide supportive services to these members. And I'll get into a little bit more of that, but really they're looking at, transitioning care from an outreach team. And now you can help them go look for an apartment in the community. Once they move into their apartment, you can continue to visit them. You schedule, treatment plan goals and the duration in which you're going to visit them to really try to help focus on sustainability in housing. So understanding the terms of their lease, working on income improvement, all that stuff we need to do to help them really stabilize in housing and stay there for the long term. So we're looking at the provider qualifications across all of these different services that we're looking to implement. And so a couple of the important ones to note is they must be in good standing with their licensing, certifying, or credentialing body. So if we do set up the ADHS license for enhanced shelter, they would need to make sure they have that first too. And then also when they enroll as a provider type for enhanced shelter with the access system, we would make sure that they are in good standing. In our pre-tenancy tenancy support services, we're looking at our existing outpatient providers to be able to onboard as H2O providers to provide that service. So they would be required to have their good standing with their license for their outpatient clinic. They also must enroll as community assisters and engage with our closed loop referral system. So we really anticipate, that we're going to be trying to do essentially like an immersion of, there are these various community-based organizations right now that are providing shelter services, that are providing outreach, And we really want to be able to streamline our connection to those services and understanding of how our members are utilizing those services. So maybe if a member is currently residing in shelter, but is also on an ACT team, we really need to be able to make sure that, the ACT team is aware of the fact that the member is in the shelter so they can quickly begin to start their services, and supporting the member with being able to stabilize, as opposed to what happens right now is there's no communication across those systems. So the ACT team is outreaching the member, the shelter has them, the shelter's trying to get case management, so essentially through the closed loop referral system, as we work to build that out, being able to have one system that's able to identify what referrals have been sent for these members, did they receive it and access these services, and communicate it back to the other parties involved in their care. Really important as I get into kind of the discussion around our assessment and treatment planning process next, we also want to make sure we've got really good oversight of these new projects. And so that will be the responsibility of our managed care organizations, of our Access Division of Fee-for-Service Management, or our Access Housing Program Administrator when it comes to the rental assistance. So some of the provider qualifications that we've included that we want to make sure we, pull through all of these different services is this low staff to member ratio. So what we're going to do when we get into the rates and reimbursement work next, once CMS approves this, is really figure out what is our rates and reimbursement structure that we need to have into place that can make sure that providers can keep these low staff to member ratios of a 1 to 15 or no more than 1 to 25. We also want to make sure they have demonstrated skills and capacity to work with the population. And so what we're going to do is our clinical staff has really worked to determine different H2O modules that these providers would need to go through. And then we're going to talk about plugging it in using our infrastructure dollars into like system-wide learning management tools. So essentially, we have our Relia system now where Medicaid providers can go on and receive specific training. So we would also look to try to develop that further to say, okay, if there's a community-based organization that's providing these shelter services, how can they have access to these training modules to learn and become certified in like motivational interviewing, harm reduction, understanding stages of change? So we're pushing out the like standardization of training across the system so we could try to get to a standardization of the ways in which the members receive these services. We really want to try to also reduce the assessment and treatment plan protocols for this, because what happens right now is, you've got a member experiencing chronic homelessness who is in need of support services. In order for the provider to start billing the Medicaid covered services, as we know, they need to complete the full biopsychosocial, they need to do the integrated care plan, which is fantastic. It's very good that we get that thorough historical information about what's going on with the needs of our members. But what happens sometimes is the member's not ready to disclose all that or sit down for that lengthy time to do that assessment. So we would work on the 1115 waiver services only for the H2O, doing a streamlined assessment process where they would do what we call our PROPAR right now, or another approved health-related social needs assessment tool. That would be the assessment tool that's required for them to be able to implement services. And it takes about 15 to 40 minutes based on the provider and the member. So definitely streamlining that assessment. And so the staff can start, essentially billing the Medicaid services as quickly as possible. So really they can get the services to the member without having these administrative, issues come into play. We also would require that they attend the continuum of care outreach collaboratives and case conferencing meetings. So this is really where we have all of our existing HUD resources coming into our community now that are providing permanent supportive housing, they're providing rapid rehousing. And so we don't really necessarily talk together too much right now. So we would really work to make sure that, these Medicaid covered services through the H2O services are participating in those case conferencings and collaboratives. So again, we're connecting and streamlining resources. What this could do is add additional subsidies, long-term subsidies to our pool of potential subsidies we can transfer members to, because they also have available resources. We would have them use the homeless management information system, and then really important, implement evidence-based practices that we're supporting right now, Housing First, SAMHSA's Fidelity for permanent supportive housing, motivational interviewing, all those different things. We would also require, again, so we're going to do the ADHS license for the enhanced shelter. That way we're able to make sure that they're meeting requirements for CFR around habitability for shelters. So really it's that it's a healthy, safe location. It has good air control, essentially good climate control, and also that each member has their own private space to be able to store their belongings. We would do a CARF accreditation requirement for community housing and shelters. And then really important for all of our rental assistance program that each unit that we're paying rental assistance on has a completed housing quality standard inspection completed, so we can make sure that the locations in which our members reside meet housing quality standards. So then we got our infrastructure dollars, and we're getting close to the end. So sorry for going over quite a bit, but we have our infrastructure dollars that were also as a part of this. So we have $13 million annually to be able to put up infrastructure to meet infrastructure needs, to be able to set us up for success for the demonstration. We do need to use some of those dollars, though, to cover some of the outreach services for members who are not yet enrolled in Medicaid. But outside of that, what we're really looking at is trying to update technology. So, think about our rural areas. Maybe there's a rural area right now where we know we lack services in that area already. And so if we can try to help create a system where we give technical assistance for community-based organizations that are in that area right now to be able to onboard as a Medicaid provider through 1115 waiver, we actually then will be giving that agency the resources to potentially be able to do an expansion. So we would be looking at doing technology for how folks can become access providers, how they can also comply with requirements. So maybe we need to help fund them for the CARF accreditation, or give them the resources to do the CARF accreditation, give them access to our learning management systems. And we will also use some of the infrastructure dollars to meet the needs of our access staff. That will help us develop the policies and then do effective management from the access level. All right, so next steps. Our next steps are to continue to engage the community and receive stakeholder feedback in the development of our plan. And then once we have our plan completed, we would submit it to CMS. As Alex mentioned, it's due in April. Once we get the approval from CMS, or if they want to go through further negotiations, we would then take that information back, of course, to stakeholders. But hopefully they say, hey, you've thought through everything and we want to give you the green light. And then we get to shift over into rates and reimbursement. That's really where we get into the weeds on, okay, what would we pay as a per diem rate for our members to reside in these enhanced shelters? How would that claim be submitted to access? So working through all of that. And then once that's done, we will work with our community members and any H2O onboarded provider to be able to implement these services into our community. And that's it for the presentation. We'll open it up if there's any additional questions. Thank you all so much.
Well, that was great. I'm sure everyone has questions. I think you've answered all my pre-submitted, except for how is Home Inc. related to the initiative, since they're the housing provider? How do they play in with all of this?
Excellent. Yeah, so our contract is actually with ABC, and then ABC subcontracts with Home Inc. And so for the rental assistance portion of this 1115 waiver, we would give the funding to ABC and Home Inc. so that we are building upon our existing standardization of this statewide administration of these housing dollars. So they would administer the rental assistance portion of the 1115 waiver.
Okay, other questions?
I have a quick question, and this may be the wrong people to ask in the wrong forum, but very often there's a SMI individual that family is having to take care of. And is there any voucher situation available for that situation? I mean, we have mothers, families taking someone into their home, having to take time out of work and care for them. That is removing them from being a burden to society in that case. Is there any way that a voucher could be used for maybe rent situation at home and that kind of thing?
And I hear you on that fully. I think the challenging thing is just the lack of resources. So if we, look at, we have X amount of dollars to pay for rental subsidies, and we have members currently, residing on the streets or, in an institution and unable to discharge because they don't have any family or any safe location to be able to go to. Right now, the system is prioritizing those individuals because we lack available resources. So we're still going to need to do a prioritization for the 1115 waiver services, but hopefully through this continued demonstration and success, right, then maybe we'll be able to continue to expand resources to continue to meet, the housing needs for those who are staying with family as well.
Thank you. Yeah, we have it's a difficult situation where parents are forced to say, sorry, my kid can't come here, because then they don't get services. And anyway, you're aware of this, it sounds like. Maybe someday
We'll
I
have
do
a
suggest
solution.
oh, sorry, did someone have something?
I was just gonna say, I think that's part of what, like, some of those transitionary periods are part of what we're hoping that these services will help with, right? When folks are exiting an institution, potentially exiting homelessness, at that precipice of homelessness because of the current living situation is no longer tenable, exiting foster, the foster care system, those are really the life situations that we're trying to hone in on and target the target population within those member situations to provide this 6-month bridge, so that if applying for a housing, an SMI housing voucher is the appropriate path forward, there's that stable, that place to stabilize for that 6 months as they wait for that housing stock to come up, essentially wrapping around the supports during that intervening period to make sure that once that next step towards permanency is taken, the members prepared and all of the rest has the resources in place, etc. I think in its ideal form, that's sort of one of the situations that these resources can help address, and then layering the enhanced shelter sort of model on top of that as sort of an additional resource and expansion in essentially the beds that are available for that 6-month period is meant to sort of, at least in part, address some of those kinds of situations.
So David?
I was just going to add, this is really where that coordination piece comes in. I mean, one thing that I think Liz CMS has made it very clear, and HUD has made it very clear. HUD has made it pretty clear they don't want to pay for a lot of services, right? They pay for housing, vouchers. And on the flip side, CMS, not Access, but CMS has made it very clear, we will not pay for long-term housing, right? We will pay for these transitional models. We will pay for these outreach services. We will not pay for long-term housing. You should be talking to HUD. And so really one of the big efforts that's going to happen between, ADOH and Liz and Access and the PHAs, that we have 27 housing authorities in Arizona or something like that who have vouchers, and these Section 8 vouchers you guys are talking about they all have different eligibility requirements. They all prioritize different things. One of the things we have to do as a state or as a community is really try to start linking these various resources, as Liz talked about. So whether it's attending community of continuums of care in the homeless system, whether it's working with our housing authorities, whether it's working with these other systems, the really hard work is, as hard as everything Liz just described, we're a breakthrough nationally. I mean, we're one of 8 states that has this privilege right now to have these resources, but the real challenge is going to be trying to braid all these systems together to work as a single system, the way that Liz and all of us have always intended. And I'll just say, last thing from a housing standpoint, what I want to, give everyone in this meeting credit for is a lot of the stuff you're hearing Liz describe is the feedback you've given, right, about these gaps and challenges. And it's exciting to see how they've thought through and really tried to create bridges for a lot of these gaps that have been identified in our community. And this is probably the best chance we've had to really address a lot of them. So it's just really exciting. But now the commitment is to get the housers there too. So thank you.
Thanks, David. Summer, you have a question or comment?
Yes, I do. One of the things that I've seen occur with my brother specifically and others with SMI and a criminal history is they have, an even more difficult time seeking services and have been, like my brother had been denied from flex care before because that specific provider was unwilling to take him considering his criminal charge. Is that going to be an issue in regards to this program? Can you deny individuals based upon a criminal history to access to care?
Are not going to, we are in our policy for the enhanced shelter. I think that's where we can try to address it most. We are not going to place requirements around criminal background checks, essentially, right? So we will actually require our enhanced shelter providers to limit any criteria around criminal background to the greatest extent possible. The only area I think we have to be cautious about is that they also will need to onboard and be have appropriate zoning, essentially, with city ordinances. And so that's where we may see some stipulations placed in by the cities around specific criminal background and members not being able to reside. In the access level, we will be working on, trying to remove those barriers for the enhanced shelters. The only other thing with the, the rental assistance around leasing up in units is we are looking for landlords in our private sector community to be willing and work with our members so they can lease up in the community settings that they desire to reside. So that would also require that those specific landlords and property owners, they will have their own, requirements around criminal background that we would not necessarily have control over.
Okay.
Okay, thank you.
I know that, oftentimes at hospitals, even state hospitals, there are people ready to discharge, but they can't find housing that will accept them if they're complicated cases or if they have any violence in their past or whatever. So that's something that we're going to somehow have to fix. Now, Jill, you have a question? You're muted. Okay.
All right. Well, my situation was that my son has been in the hospital 6 months, but along that time before, just shortly before that, we were looking for housing, and then they terminated they said, I got notification that the housing program, that we were terminated from that because he was absent from the dwelling longer than 90 days. I had no idea about that. And he's ready to be released from the hospital. And now I'm appealing the fact that they terminated, the HOM terminated him for the voucher system. What do you do about that? If somebody is in the hospital that long, and also, I wasn't even aware. How does one know all those rules? I don't know if I'm making myself clear. We now have to find housing, and I'm appealing the fact that they closed the voucher system for him. And we need housing. So we have an appeal hearing on Monday.
Yeah, you are clear. I worked within this issue for quite some time. It's actually a requirement through HUD, because you also at the same time you have to pay out on that unit, whether the member is residing there or not. So just out of consideration also for like fiscal responsibility, you don't want to continue to pay a landlord for a vacant unit, for an extended period of time. So HUD actually has the requirement of 90 days. You can request a reasonable accommodation. So the clinic can request a reasonable accommodation to extend that time. So I think, I'm going to leave my contact. So if we want to get into like more member specific kind of information.
Yeah. I would appreciate that. I didn't make it clear. No, actually, we agreed to have him leave the house that he was in. It wasn't appropriate for him.
Okay.
But then our desire was to seek and find the correct housing. And I received notification that he was no longer acceptable for the program, to look for and utilize a voucher because it had been too long. It had been more than 90 days. Well, he's still in the hospital. He's ready to leave the hospital. Now we need housing. What do you do?
Let me give you my contact, Jill, so we can reach out if we're going to. So for more like member specific stuff, we'll discuss it more in a private setting. But
there is an appeal Monday. I wish somebody had told me though. I mean, as his mother, there are all kinds of issues I have to know about, and I do. But where do you see those rules about 90 days? I mean, why didn't somebody tell me we should be on top of that?
Yeah, there should have been a lot of communication, at the hospital level and everything with kind of what was going on with their permanent housing plan. What happens is, we only have so many resources. And so when a member is out of their unit for extended period of time, we do need to try to stop paying on that unit. But then what happens?
We did stop paying. That's rescinded or whatever, he's not in the unit, somebody else could use it. Right, it wasn't being paid for. Clearly, that was
one thing. Hey, Jill.
Yeah.
One thing. There's a difference too with vouchers, and our housing people can jump on in. But some projects, like lighthouses and others, are project-based vouchers. So the voucher stays with the project, versus and they go into that. When they leave, they don't take the voucher away. Someone else moves into that property because it's project-based instead of person-based.
Oh. Well, that wasn't clear either. They just said that they couldn't really search for him anymore. 90 days,
I'm just saying that there are different types of vouchers. Some are based on a project, or they have
It says, notification that your participation in the Arizona Behavioral Health Corporation Rental Assistance Program will be terminated. They terminated it. I had to appeal it. So he had rescinded so that they could look for another place. And then they said, no, it's been too long. Too bad. And now I'm appealing it Monday. So what's the best way to appeal it?
I think if you talk to Liz offline, I think she can give you exactly what you need to do.
Okay. The meeting is Monday at, I think, let me just tell you so I could speak to you before that, if that's okay, Liz. Sorry, the meeting is at 1 o'clock on Monday. Is there any way I could speak to you Monday morning, Liz?
Yeah, any time now between Monday, I put my email.
Oh,
in the
right. Oh,
chat,
right.
so
We
yeah.
could speak this week would be great.
Yes, just reach out and we'll I'll let you know kind of next steps.
Is there a phone number or just, or you want me to email you first?
Yeah, if you want to shoot me an email, we'll get something scheduled.
Okay, thank you.
Thank you.
Okay, any more questions, or you guys are free to stay for our stakeholder meetings, and I mean the remainder where patients, not patients, families may talk about parts of the systems they're struggling with. Often there's a housing element involved, or you may want to choose to drop. It's up to you. But at this point, I stop the recording.
Well, thank you all so much for having us. I'm going to jump off.